Respected chairperson, seniors, colleagues, and my dear friends. This is regarding bariatric surgery anesthetic management in an elderly patient. So this was a case scenario. A 64-year-old lady presented to us. She was 160 centimeters tall, 147 kg, and her body mass index, that is the Quetelet index, which is derived by dividing the weight in kilograms by height in meters in square, came to a 57.5. So she was in super obese, which has been variously described as BMI more than 50 and more than 55 in various journals. So she has been trying different weight loss programs for quite a lot of years without any success, obviously. And she had been advised of bariatric surgery almost 10 years back, at which time she was reluctant to do that, and now she has presented for the same. She was counseled, a psychiatric profile was done, she was put on a 1000 kilocalorie solid diet for about 21 days, by which she lost around 9 kilograms, and she was finally posted for a laparoscopic sleeve gastrectomy. So the thorough pre-anesthetic examination was done. She was diabetic, which was fairly controlled with premixed insulin and metformin. She was hypertensive on olmesartan and amlodipine combination. And the problem was that her BPs were not being checked because it could not be checked with a normal BP curve. So she had all the features suggestive of obstructive sleep apnea, disturbed sleep, daytime sleepiness, etc. And the functional capacity, which was very important to be assessed, especially in an elderly obese lady, very difficult to assess because she had bilateral osteoarthritis of knees, she couldn't walk. So finally we managed from history and whatever mobilization we could do, we estimated to be around metabolic equivalents around 3 to 4. 4 being a moderate functional capacity, it was just below that, which was not very good. Her airway status, we were expecting a difficult airway from her. We could see from her site itself. She had a short neck, she had a posterior cervical fat pad, which made her neck which could not be extended. Again, she had a thyromental distance which was too small. A myometric glass, which is assessed by opening the mouth and putting out the tongue, could see only her epiglottis. Sorry, only the uvula. That was myometric 3. Her neck circumference was 38 centimeters. This is important because any circumference above 40 or above denotes high chance for 1, obstetric sleep apnea, 2, difficult intubation. So she reached very near that. So this was the lady. You can see the pendulous abdomen and the necrotic fat. This was someone had diagnosed filariasis of the abdomen for this, and I think she was prescribed something for this. This is actually nothing but fat necrosis of the pendulous abdomen. And here you can see the BP curve. Actually, it is on the forearm, not on the arm. And this is an extra large cuff, and that just fits her forearm. So all preoperative investigations, evaluations were done, and her HbA1c was around 7.5, which denoted a fair control. Her echo showed a concentrated left ventricular hypertrophy, which was due to the systemic hypertension. But luckily there was no pulmonary hypertension, and her LV systolic function was good. The chest X-ray showed a bilateral haziness, low zone, but we weren't very sure whether that was due to the soft tissue overshadow. And the PFT showed a mixed ventilatory pattern, and the room air blood gas were within normal limits. Other thyroid profiles, cortisols, B12s, everything were within normal limits. So optimization, as part of optimization, our pulmonologist, endocrinologist and cardiologist evaluated her and optimized her treatment. The dietitian, the physiotherapist were involved early in the course of the treatment itself, and she was put on aggressive respiratory therapy. She was put on deep breathing exercises, incentive spirometry, steam inhalations, inhaled bronchodilators, and of course deep vein thrombosis prophylaxis. Because she is obese, she is old, she has high incidence for, she's being planned for a bariatric surgery, high incidence for thromboembolism. So we planned for pneumatic compression devices, graduated pressure stockings, and we started on long liquid heparin. Enoxaparin was started, 40 milligram subcutaneous twice daily, 2 days before surgery, which was continued till 12 hours before the surgery. Again, she had high risk for aspiration, so put on H2 blockers and prokinetics. Insulin therapy was optimized to achieve strict glycemic control, again vital for a good outcome. Antihypertensives, regular antihypertensives are continued till the morning of the surgery. Only thing is that olmesartan was discontinued and only amlodipine was given. So what were anesthetic concerns? One was, of course, her elderly age group. She was a diabetic, hypertensive, and has obstructive sleep apnea. Altogether, have high chance for post-op and intra-op cardiorespiratory complications. Positioning was an issue. These sort of patients have high incidence of neurological abnormalities and pressure sores, so we needed to take care of that. Also, if position is not proper, there can be high incidence of rhabdomyolysis. Airway control and IV access again were nightmares. Monitoring. How do you measure BP for her? So we were planning invasive monitors. Drug calculations. We had to pre-calculate drugs because some drugs had to be dosed according to the total body weight, some according to the ideal body weight, while some according to the lean body weight. So we had to pre-calculate the drugs. And there's something known as OSMRS, or Obesity Surgery Mortality Risk Score. There is body mass index. Any body mass index above 50 is given 1. Male gender is given 1. Hypertension is given 1. Any risk factor for pulmonary embolism is given 1. And age more than 45 is given 1. So she had a score of 4 out of total 5, which kept her in a class C or very high risk for mortality. So intraoperatively, apart from all the routine monitors like electrocardiogram, NMBP cuff, the pulse oximeter, we instituted an arterial line in the left radial artery, CVC catheter, a central venous catheter, the right internal jugular vein. The end-tidal gases, including carbon dioxide and the anesthetic gases, were monitored. Her airway pressures were closely monitored, also temperatures, urine output, glucose. She was induced with fentanyl and propofol and stacking, that is, pillows and rolls were kept under her shoulders and head so that her chin was lifted.
We'll go a little fast, so we have to ask so many questions.
Had to be lifted from the chest. Maintained on sevoflurane and desflurane was used with end so that she comes out fast. Sterofundin is a balanced salt solution. It was used intraoperatively 4,500 ml. And the importance is that this is almost 2 to 2.5 times that is used for a 147 kilogram patient for another surgery. And insulin infusion for control. Surgery was relatively uneventful and she should be extubated on table. The tray patient, this is the stomach being, the part of stomach being taken out. This is after surgery. For pain, she was given local infiltrations and diclofenac. The respiratory therapy was continued. The fluid was optimized according to the CVP and urine output. She had slight hypothermia, which was corrected with forced air warming. The infusion insulin was continued and sugars controlled. DVT prophylaxis till full mobilization, and serial ABGs were monitored. Just watch these red letters, they are the abnormal ones. You can see that immediately post-operatively, from the evening of the first post-op day till the morning of the second post-op, she is acidotic. And you can see the carbon dioxide also high and bicarbonate low. So mixed picture. Also, you can see the bicarbonate, blood urea on the first and second days slightly above normal, while creatinine remains normal. So on the first post-op day, she was a bit drowsy with increased carbon dioxide. She was started on a non-invasive ventilator. We didn't want to intubate her because we were scared to intubate her. So she was started on a non-invasive ventilator with a mask BiPAP, which is bilevel positive airway pressure ventilation. Settings adjusted to her condition. And she was closely monitored for stomach inflation because we didn't want the air going into the stomach and rupturing the suture lines. Intermittently, mobilization was tried, and by the second day, we could wean her off BiPAP and fully mobilize her. On the fourth day, all SIPs were taken, and she could be discharged by the 8th post-operative day. Just briefly, in whom we did surgery? If absolute BMI 40 or above, or if BMI 35 or above with associated severe problems. And age per se is no contraindication, but bariatric surgery is much less done in elderly age group. Most of the studies say that the patients whom bariatric surgery is done, only less than 2% are elderly, that's more than 60 years. And complications are significantly high and mortality is also high. Our patient had a slight acidosis, which is a mixed picture in the post-op gradient. We attributed that to the hypercarbia, she had slight hypoperfusion, which could be corrected with fluids, and also slight hypothermia. She was managed with non-invasive ventilation, optimized fluids, warming, and strict glycemic control. So take home, age per se is not a contraindication for bariatric surgery, though there is significantly high rate of complications and even mortality. So this makes careful pre-op assessment and strict peri-op management vital for a successful outcome. Thank you.
Very interesting. Anyway, so what is the frequency that, how many cases you have done?
Actually, we're just starting off a bariatric unit. This is a patient who came for the 4th day for a contrast RO to see whether there is a leak.
Oh, this is a field where I can do a lot of help to this type of people. Anyway, open for discussion. Very 1 or 2 questions only. We are nearing the time deadline. So you are very hopeful. The future is very bright. What do you think?
Yes, definitely.
I think so it has been a very interesting presentation. I think you can have statistics. Maybe after a few years we will present the 100th case. Okay, so